I'm Associate Professor of Medicine and Infectious Disease at Northwestern and affiliate faculty with the Institute for Global Health Center for Communicable Diseases. So thanks for taking the time to join us for our latest installment of the Institute for Global Health First Friday seminar series, which is co-sponsored by the Biomedical Engineering Department. Please take a moment to follow us on Facebook and Twitter at FSM Global Health. I think all the details are on the slide. And in addition, please note the Institute for Global Health is currently accepting applications for COVID-19 for both research and project support for affiliate faculty. And those applications are being accepted on a rolling basis through June 1st. And for more information, you can visit the website. So today we're thrilled to have with us Drs. David Kelso and Tom McDade and Cara Palamountain, who will be discussing some of their work on COVID lab diagnostics and considerations for scaling up testing on a more global level. I think we can all agree on how timely and important this topic is today. As you know, testing is critical for identifying COVID cases and prevention of further spread of infection through contact tracing. And access to widespread testing is going to be of paramount importance for countries to be able to safely reopen businesses and activities. So just the sheer volume of testing that's been projected for not only for the US, but also globally emphasizes the need for the development of accessible and affordable tests and platforms with very high throughput and rapid turnaround. And some of this will be addressed today. So our first speaker is Dr. David Kelso, who is an associate professor of biomedical engineering with the McCormick School of Engineering at Northwestern and director of the Center for Innovation of Global Health Technology and co-founder of Molecular Diagnostics. His research interests are in analytic instrumentation with medical devices and biosensors, as well as kinetics of antibody and DNA binding reactions. And he will be discussing some of his rapid molecular testing platform for COVID that he and his group are working on. Dr. Tom McDade is the Carlos Montezuma Professor of Anthropology, a faculty fellow within the Institute for Policy Research and the director of Cells to Society. And his work is primarily concerned with the dynamic interrelationships among society, biology, and health over the life course, with an emphasis on life course approaches to stress in the human immune system. And he's going to be talking to us today about COVID antibody testing and work he's been doing on a SARS-CoV-2 enzyme immunoassay using dried blood spots. And then finally, Cara Palamountain, our third speaker. She's the president of the Global Health Foundation, the co-founder of Minute Molecular Diagnostics with Dr. Kelso, and a research associate professor and lecturer of global health within the Kellogg School of Management at Northwestern. Cara has managed over 50 Kellogg field research teams conducting market entry analysis for medical diagnostic technologies in over a dozen African countries. And she's also collaborated with a number of commercial diagnostic companies with funding from Bill and Melinda Gates on both molecular and immunoassay platforms for low resource settings. And she's going to be discussing some of the considerations to scaling up COVID diagnostics and low and middle income countries, reflecting on some of her experiences in this field to date. So each speaker is going to be talking for about 15 minutes. And there'll be time for questions after the presentation, so please feel free to submit them as we go along on the Q&A feature at the bottom right-hand corner of your screen. So with that, Dr. Kelso, I'll turn the lecture over to you.
So can you see my screen here now? And hopefully I turn on my slideshow. And yes, so let me introduce one other member of this team that isn't present today. That's Dr. Sally McFall, and she's the brains behind the assay part of this. I'm the engineer, and all we do in the lab is build a system around her assay. So most of the ideas you're going to see here today are really Sally McFall's idea. We've been working together, as was mentioned, through CITE, the Center for Global Innovation in Health Technology, for 15 years now. It was started by Bill and Melinda Gates grant back in 2005, and we were partnered with Abbott and Alere, which is now part of Abbott again, to make diagnostics for the developing world. And we did PCR assays for the developing world, did it in a an antigen assay for HIV for the developing world, and turned over the license out that to Quidel. So one of the projects from that first Gates Foundation is finding its way into the developing world. Sally now heads up the center for HIV in the developing world, this OCTERN, and point of care technology research network that's doing AIDS with Dr. Murphy. And so we're all connected together and have been working for resource poor settings for a long time. This was a new.
Can I just interrupt you? We don't see your slides.
I thought I was sharing the screen.
Yeah, that's just.
Try this again. Try this.
Yep, that looks like it's working.
Does that work? Apologies. WebEx is new to me. So as I was saying, you missed the logos, but nothing of any particular importance there. We were well on our way to having a point of care clinical system for the use cases that we see in doctors' offices and emergency rooms and places in where fast turnaround times were needed, but we had never seen the problems that the use cases that came up with the COVID pandemic, where not only did you need fast turnaround, but you also needed very high throughput. So the passengers getting off of cruise ships and airplanes, drive-through testing, first responders, the people entering nursing homes. There are many, many situations now where you see long lines of people that don't want to wait for long periods of time, that need immediate disposition one way or another. Out here in these parking lots, there's no power, there's no lab facilities, there's no information management, and people are wearing PPE, and there are not a whole lot of lab technicians or trained personnel around. So we looked at those situations and said, what can we do with what we have in the lab? Like I say, that was on its way to the doctor's offices, and we came up with, I hope I can show you. So this is what is being used there right now. There are two systems that we see being used. The Lear Admit ID Now, which you see on the left, which is being used downtown. They're being used in your drive-through sites over by the emergency department and Lanier, where you take a sample, put it in put this little base in here, put the swab into this little container, swish it around, put the container into the back, start it up, and 13 minutes later, you get an answer, positive or negative. And this is a rapid isothermal technology, which basically does one at a time, but you stack these up side by side and can match the throughput necessary to keep up with your ability to sample. The other system over here, the Cepheid Gene Expert, this you can run 16 tests at the same time over here. This is not one from your site, it's from back in Connecticut, but you have one of these instruments or a smaller version of it, and you take the swab, put it in a thing, load this little cartridge, and off you go. This one, however, doesn't produce an answer for 50, 60 minutes, which is why they have a lot more units here, so you can keep them all processing in time. And with this one, the person has to wait for an hour before they get a result. So this was a system we had under development for doctors' offices, and we also had you putting the swab into UTM and then putting that into our cartridge. And we said, well, let's get rid of that step so that you can eliminate the last step required to do this. And so the system that we are now testing in the laboratory, you place the swab in the cartridge, swirl it, throw the swab in the biohazard bag, place the cartridge into the instrument, and walk away. Well, walk back to the person who's doing the swabbing and get a sample from them. There are two pieces in this. The picture on the left here is what the prototype instrument looks like now. You wouldn't want to put that out on the line, but we'll show you what it's going to look like when it gets wrapped up. Turns out it was found out a few years ago that the only thing limiting the time it takes to do PCR cycling is how fast you can transfer heat into and out of the reaction chamber. We came up with a way to transfer the heat really fast on the engineering side. These are temperature profiles that you see down here below, and unlike the PCR instruments you may have seen, there's 5 seconds between these peaks, and we can do 40 cycles in under 5 minutes, and that's to say a true negative. If it's a positive, it's going to come up much earlier, which you see in this data. So this one way out here is the negative or this is a very low positive that's coming up, but your high positives will come up after 16, 18, 20 cycles. The other part, which the name of the system comes from, is the selective hybridization. And unlike a lot of these systems that precipitate all of the nucleic acids onto the solid phase or don't do any sample cleanup, we grab the virus, and we'll grab any virus for this application, or be as selective as we have to get a good assay. We're pretty selective when we go for TB, which is where we discovered the advantage of this. And so the SH is for selective hybridization, the DA is the diagnostic analyzer. And the selective hybridization process takes another somewhere between 5 and 7, 8 minutes. So the two together, we think can turn the test around in right around 12 minutes, maybe 10 if we can get it going really fast in the next couple of minutes, but fast enough to keep up with the flow that you're going to see. So what we've done is, if you see this unit, it's only 3.5 inches wide or so, and so we can take a whole bunch of those units and put them together into a cabinet that can drop into a suitcase that you see over here, which the technician that's gonna operate can check through his luggage on the airplane if you've got to go to Guam to screen everybody getting off of an aircraft carrier, or just out into the parking lot to run it for the day and then take it back in. When you set it up on the table, you've got the operator would be in a chair in front of it. They can see the status of everything, but there's a little light on each of these that when a unit's available, you just take the cartridge, drop it into the slot, like I say, 10, 12 minutes later, out comes the answer. What we also realized at the time was that keeping track of the information and all of the people that are queued up waiting to get an answer was another part of the bigger system challenge that needed to be addressed. And for that, we've come up with how we think that the information flow and management could be handled out here in the parking lot outside Levant, or in these high throughput situations. And we've where there is no Wi-Fi, where you don't want to have a bunch of cables running around on the ground. So the entire information management system is going to be cloud-based, where your devices are talking over the cellular network to a server in the cloud and being coordinated. So you're all probably very familiar with this process now, where the first thing you want to do is see that the person belongs in line here to get their, if they are, get their personal identifying information, so that you can deliver the results back to them, and at some point in time get their results into your medical information system. But for now, we're just trying to make sure that the person that gets identified here, or multiple people in the car, get a report at the other end of the thing. So what we see handing them here is a little packet that's got the swabs and a couple of tags in it, where we leave one label with the person who's being screened, stick it on their car or hand it to them. If there's a number of people, we still have to get down and see these. That person then, but we capture the information on a phone here photographically, send the pictures up to the cloud. I'll talk about what happens that next, and then hand them the little packet, which they carry on down to the next station, and the swab to this is the nurse. This is the one medical person that has to be in this whole loop to collect this sample, especially doing the NP swabs. And they're going to collect the swab, put it into a dry tube in this little packet, and then that little packet gets handed to the person here that's running the test. So they'll take the swab out of the test, do what I just showed you, drop it into the cartridge, swirl it around, and get a good elution, and then plug it into the instrument to run the test. When the system is done with generating the answer, it will tell the cloud what the result was and send along the personal, the individual's identifying information, so that it gets into the same record as this one was. We think that can probably be done with artificial intelligence up here in the cloud. If you got a picture of a driver's license, or a picture of a passport, or whatever the doctor's order that told them to get in line, whatever the information was that needs to get into the system, will be captured on this image and sent to the cloud. But if you can't, we can have a person here downloading the pictures or working closely with this person, entering that information, so that everything gets tied together here. The answer from the test, the tagging information, and then the report gets sent down to another off-the-shelf device, which are these point-of-sale terminals that have a little thermal printer. So then the person that finds the right recipient of this prints out a report, hands it to them, and they're on their way. So there'll be 10 or 12 people in line here waiting for an answer, or 10 or 12 cars here. And we hope, and we think we can keep this line flowing and keep up with all the data. To make all this happen in as quick a possible time as we can. So as I say, we read it, we get the fast turnaround time. Everything's unrefrigerated, so they can sit in a warehouse for a couple of years and come out when they're needed for whichever pandemic we're trying to deal with. And the other hat that I'm now wearing is Minute Molecular Diagnostics. So we've created a company with the help of Invo down there to commercialize this. The backers of Abbott are not these companies, but they are senior executives from these companies: Abbott, Chiron, Medtronic. We even got the patent lawyers involved in this, and we will take this system out by the end of this year, and hopefully have it available to do some testing in the next cycle when it comes back. Lots of people have been involved with this. Sally and Kara, you already heard mentioned. The engineering is pretty much being done by outside consultants now. Tom Westberg designs the hardware. People here doing the electronics. This was the designer of the optical system on the Gene Expert. These are marketing and other people, and these are the people inside sites. So there's a group of 10 there. Sally heads up this team. Matt Glucksberg is now the head of the lab, which and mostly these are all molecular biologists and life scientists. This is the one engineer, Abhishek Agarwal, and Tina Coynes. So there's two card-carrying biomedical engineers here, and some of the people are being cross-trained. So I think Matt Butzler is becoming a good engineer. He's a molecular biologist. Tina, she's learning how to do assays in molecular biology. So it's a big team effort with a lot of different skill sets, but all the right people to get this all to happen fast. And that's what we hope to have to apply to the situation when we need to do these kind of screenings by next fall, and probably for the foreseeable future. So with that, I think it's time to switch from detecting the virus to detecting the antibodies for the virus. So I'm going to pass it on over to Tom, and really interested in seeing what he has on the antibody side of things.
Terrific. Thanks, Dr. Kelso. Dave, that was great. All right, so I think you can hear me, and if I get the presenter view, I should be able to share my screen. How's that look to everybody? Does that look good?
Yep.
Okay, terrific. All right, so this is a complementary approach, and it's a pleasure to be here to share this work with you that's been happening very quickly over the past 3 weeks in my lab, and this is a collaboration with a group down at Feinberg, which I'll talk about in a second. Serological testing or antibody testing in general works on the premise that our bodies respond immunologically to viruses, bacteria, in this case a virus. And this is just a simple chart here showing you that after exposure, viral load will increase, and that relates to symptoms, and then they decrease with recovery. 3 to 4 days after initial exposure, your body will start to produce IgM antibodies, which are detectable about a week later. And then, a week to 2 weeks later, subsequent to that, your body will start to produce immunoglobulin G antibodies, and they're notable because they're long-lasting. So they can be detected months and perhaps even years after that exposure. So they become a useful retrospective tool to identify cases, and it's gotten a lot of attention. It's like, I'm trying not to actually expose myself to too much media these days, but every day there seems to be something on the radio or in the newspaper about antibody testing, both good and bad. There was a Science article almost a little bit more than a month ago that started to talk about scientific applications. And here I've summarized, I think, the 4 areas where people are talking about the utility of antibody testing in the context of coronavirus. The first is a basic sort of surveillance question. What is the true seroprevalence of the virus in the community? And what is the true denominator? With limited testing capacity, as Dr. Kelso was talking about, we're only testing people who are sick and present with symptoms that we suspect of being the result of COVID or the coronavirus. So we don't actually know where the virus is in the community, how many people have been infected. And this seems to be particularly important here, given how many people have mild symptoms. And many people may have no symptoms at all. So where are these cases, and who is most vulnerable to becoming infected? The second has to do with the evaluation of policies and behaviors that might mitigate transmission in the community. Our understanding of this outbreak and of this virus is based almost exclusively on the study of the most severe cases in hospital-based settings. But this is a community-based problem. It's having tremendous impact in the community, and it's being spread in the community. And we're sort of, I think, working in the dark in terms of what are the best practices for mitigating spread. And so a retrospective evaluation with antibody testing can help us understand better what kinds of policies and behaviors might mitigate future outbreaks. We also don't know much about what predicts mild infection because we're not identifying these people. So we could retrospectively identify people who tested positive and determine whether they had mild or more serious infections and model the predictors of whether someone is more likely to have a serious clinical presentation and course. And then we can also use information based on antibody screening to predict the course of future outbreaks. And so if we understand where the virus is and how it's being transmitted in the community, that can inform future predictive models that can be used to forecast fatality rates, need for critical medical equipment like ICUs and ventilators. And also if, and this is a big if I'm gonna get to in a second, if a higher level of antibodies in a serological test indicates a certain degree of immunity to subsequent exposure, that's really important information for modeling future outbreaks as well. Now, one of the perils I think we should all be very careful about in talking about antibody testing is this assumption that prior exposure does indeed equal future immunity. And we just don't know that at this point in time. And there's a lot of work on neutralization assays to determine what antibodies and what levels of antibodies may indicate future immunity to future exposures, but we're not there yet. And any talk of use of antibody testing for passports, certificates, I think is premature. And it's also unfortunate to see the politicization of some of the antibody testing results, where some people say, well, the seroprevalence is so low based on this first wave of antibody testing, therefore we can open things back up and yada, yada, yada. So that's something I think we need to just keep in mind. There's also another problem, and that's a quality control problem with the first rollout of a lot of these antibody tests. So the New York Times here, I think, just sums it up nicely when they say that there are lots of tests, many made in China without FDA approval, are inaccurate and doctors are misusing them. And the demand is really high, which is fueling the rollout of these tests that are not really of high sufficient quality. Fortunately, there are groups, a couple of different scientific groups who are imposing rigorous criteria to evaluate the quality of many of these antibody tests. And this is one recent reprint, and you may have seen there's a big COVID-19 testing project, collaboration of folks in the Bay Area. So the first wave of tests were, and the ones that people are talking about, that many of which have problems, are based on the principle of lateral flow immunoassay. And it's basically a pregnancy test, but it uses blood, and you drop blood and some diluent into the cartridge here, and then it flows down the filters, and you get a control strip and then a positive strip if you test positive for IgM in this case, or IgG in this case. And a nice advantage of these kinds of antibody testing platforms is that they're point of care. They can be delivered by a healthcare provider in that moment in interaction with someone who may. They only require a couple of drops of finger stick capillary whole blood. They return results rapidly, 5 to 15 minutes, and they may be useful for collection in the community because they can rely on finger stick blood rather than venous blood. Now, a downside is that these tests generally almost always deliver qualitative results. There are issues with quality control, insurance, as I mentioned earlier, and they still require a healthcare worker to administer the test. They're actually a bit cumbersome because you have to collect the blood in a pipetter and transfer over a diluent and transfer into the cartridge. And then you might also need some support interpreting them. So it's not something that is readily, easily implemented by people individually in their home. And it's also a one-shot deal. You get one test and there's no opportunity to retest. In contrast, enzyme immunoassays are lab-based protocols. They are quantitative, rigorously quantitative. or can be. They provide a higher degree of accuracy, and by accuracy here, I'm talking about the level of sensitivity and specificity of the test, the likelihood of returning a false positive or false negative. Retesting is possible if you store the samples in the freezer or refrigerator between uses. On the downside, these tests typically require serum or plasma, which again requires venous blood collection and engagement of healthcare workers in that infrastructure, typically collected in a clinical setting. The tests are slow. They require 3 to 5 hours to return a result. And then obviously they happen in a lab, so they require a lab infrastructure to make happen. So is there some way to perhaps take advantage of the upside of a lateral flow point of care approach with the quantitative possibilities and accuracy of a more lab-based approach? And this is something we've been working on for the past month, and it draws on approach that I've been using in my lab for the past 20 years here at Northwestern, where as an anthropologist, almost all my research is field-based and much of it is in remote international settings. Most of my work is on inflammation, and I need blood to access the biomarkers that are of interest to me scientifically. So I've been using dried blood spots, drops of whole blood, capillary whole blood collected on a filter paper as a platform for collecting blood for the past 20 years. It's relatively inexpensive, costs about $1 to get a sample. You can get a sample from almost anyone in the world and get it back to the lab in a usable form for about $1. So it's a very convenient way to take advantage of the possibilities of community-based sampling, the reach of that, the low cost, low hassle, and convenience of sampling the community. But then we bring the samples into the lab where we have a higher degree of control and more flexibility in terms of the procedures we apply to the sample. So let me just walk you through it briefly, how this happens. We clean the finger with an alcohol swab, nick it with a lancet, squeeze a few drops of blood, natural capillary flow. We try not to milk the finger, but natural capillary flow should let the blood fly out onto the filter paper where it's absorbed and dispersed at a uniform rate. This is way back. This is from Samoa, my dissertation in the late 90s. This was a day's data collection effort there. Once the samples are collected, you lay them out to dry for at least 4 hours. Overnight is fine. And then you pack them up, and then you can ship them to the lab. Alternatively, and what we're working up right now in the context of the current situation is that we can put together materials and send them to people in their home. And they can self-collect a blood spot, put it on a filter paper, put it back in the envelope here, and then they can send it back to us in the regular mail. And just a regular forever stamp right here will get the samples back to us. So it's a pretty convenient, low-cost way to get samples from people in their homes and not ask them to come out of their homes, especially when we're asking people to shelter in place. And we're also not taxing any of the healthcare worker infrastructure by having people come out to have someone collect a blood sample from them. Once in the lab, we take a hole punch and we punch out discs of blood of uniform size. You can use a simple hole punch like this. We also have automated punchers for higher throughput applications. Once you punch the disc of blood out, you put it into a test tube or a 96 well microtiter plate, and you add a buffer, typically BBS or PBS or some variant of that, and you reconstitute the blood overnight. So you basically made whole blood again, and we transfer it to our assay plate, much like we would do if it was a serum or a plasma sample. Now, earlier in my career, when I was using blood spots, I got a fair amount of pushback and skepticism that you could actually collect a sample and generate a valid result from it using a blood spot in comparison with the gold standard serum or plasma. So I like to show this quote, which is from Joanna May, who's part of the CDC's quality control monitoring program, which basically says that for most applications, you can expect the same level of quality of results with a blood spot as you can with serum and plasma. I would say that's true for most applications, but there are important caveats to that. But it's important to note that these papers are regulated by the FDA. They're certified, they're classified as Class 2 medical devices. They're certified by the CDC, and they're used in all neonatal screening programs in hospitals across the US. So they're part of our public health and blood collection infrastructure and have been for nearly 50 years. So this is a team of folks I've been working with to develop our blood spot assay for coronavirus antibodies. Beth McNally, Rich Tequila, Brian Mustansky, and Alexis in particular have been working with me most closely in this effort. We have a white paper of this method that we're hoping to get posted as a preprint any day now. And here's how the method works. So the ELISA happens in a 96-well plate. This is the virus itself. The spike protein on the outside is a large glycoprotein that's important for viral entry. And as part of that spike protein, there's a receptor binding domain, which we have been able to manufacture through recombinant techniques. And we use that as our antigen. And we coat the wells in the microtiter plate with the antigen. We take our blood spot LU8 and we add it to the plate. Of course, we do washes and all sorts of things. And basically, when all's said and done, we've built up a capture with antigen coated to the bottom of the 96-well plate. The antibody, the thing we're interested in detecting in people's blood, is captured to the bottom of the well if it's present. And then we add an anti-human immunoglobulin G antibody that's coated with an enzyme, in this case, horseradish peroxidase, which produces a color change reaction in direct proportion to the quantity of bound antibody. And so at the end of the 4 or 5 hours in the lab, we get something that looks like this, and we can precisely quantify with a plate reading spectrophotometer the degree of color change, which is directly proportional to the amount of bound antibody. So here's our validation to date. We have recombinant antibody material. This is an antibody that binds to the RBD domain of the coronavirus. And I dry blood spot samples, and we get a nice dose response. So the sample that has more antibody in it generates a higher absorbance reaction in the microtiter wells. And then we've collected a set of samples from people who are confirmed PCR positive cases of COVID-19, and we've compared those with a handful of samples collected in 2018, so presumed negative samples. And we get a wide range of responses here. And it's hard to tell here, but there's pretty good separation in optical density values between our negatives and the lowest of the positive values. So we're confident that we can just differentiate negative from positive individuals in terms of seroprevalence here. And then we also have a handful of samples where we have matched blood spot and serum samples. And then you can see the correlation here is very high. It's linear across the range. So this goes to the point that with a blood spot, we can expect the same sort of level of precision or reproducibility as we would expect to see with serum. So that's where we're at with the method. Validation continues. We're collecting more samples, positives and negatives, blood spots and serum, to more fully flesh out the validation. And it'll be very important to have additional samples to establish what our seropositivity cutoff value is. And that's critical for evaluating the assay in terms of its sensitivity and specificity, which is a huge issue right now. And this is where a lot of the lateral flow point of care devices fall short. We're also working up an application to do some work here in Chicago and Chicagoland area. Brian Mustansky's team in particular has a lot of experience with developing web-based interfaces for recruiting, enrolling, and consenting participants. So this is an ideal platform for our purposes, where we'll never have to engage a participant in person. They can enroll online. We can send a collection kit out to them, and then they can send it back to us. And we're working up to hopefully putting in motion a project where we collect up to 5,000 samples and link that with survey and neighborhood data. So we're pushing this forward in the idea of if we build it, they will come, but we don't have any funding for any of this at this point in time. So if anyone has ideas, be sure to let us know. Okay, and I think that is it. Thank you.
Okay, great. Can everyone see my slide? Everyone hear me? Okay, great. So thanks, Tom and Dave. Terrific presentations. Again, my name is Kara Palamountain, and I'm going to provide a little bit of my perspective on this from the continent of Africa, the 54 countries there. Since this is an Institute for Global Health, how can sort of these molecular approaches and those immunoassays be absorbed into sort of the African setting? As just a declaration, as Claudia mentioned in my intro and Dave mentioned, I am involved in the molecular platform that Dave talked about, Minute Molecular. But my goal here is to really provide insight for everyone here. So look and across the continent. The African CDC, led by John Nkengasong, who be part of the U.S. Center for Disease Control, has put together, he leads the African CDC, and they're reporting the cases in Africa. And there's about just shy of 40,000 cases as of yesterday, 12,000 recoveries. I just put a snapshot of some of the countries that are located on the map and have big circles. So South Africa is one of the big circles, so is Nigeria. And you can see South Africa has about 5,000 cases and Nigeria has just short of 2,000. The testing capacity in South Africa is already close to 200,000 tests performed today. So just wanted to kind of give you a snapshot of what the different countries consist of in terms of these 40,000 cases. In terms of the COVID testing that they're doing in these countries, in particular, you can kind of see the darker greens are testing more in terms of the population. There's been about 30 million globally tests performed on COVID. And, you know, South Africa, in terms of tests per 100,000 in the population, is doing about 300. And if you, the US is doing about 1,800. So, you know, that's about, in South Africa, that 300 equates to about 1.8 tests per year, 1.8 million tests per year. If South Africa had the same ratio as the US right now, that would be about 11 million tests per year. But Defined is this great organization focused on improving access to diagnostics globally in places in low and middle income countries. And they have this great website. It's just a terrific resource and have great visualizations if you're interested in testing and want to see the data cut every which way. In addition, you can kind of see the daily testing rates that different countries are reporting. And so in South Africa, they're reporting around a daily testing rate of about 22,000 tests per day. So, you know, definitely South Africa is leading the continent in terms of testing capacity. And I wanted to dive a little bit deeper into why that might be the case and what we can learn. Some of you might even be surprised that the testing capacity is this high in some of these countries. And one of the reasons for that is that the platforms that do COVID testing, the first few that were approved for emergency use authorization here in the US, also do virus testing for HIV and molecular testing for tuberculosis. So a lot of the platforms, whether it's Abbott M2000, the Cepheid Gene Expert that Dave showed on one of his slides, also the Hologic Panther and Roche, some of Roche's machines. You know, these have been put into the laboratory systems across the continent of Africa to do HIV viral load testing and tuberculosis testing. And they continue to add on to their platforms, whether it's hepatitis C, et cetera. But now with 18 million HIV patients on therapy, you know, this viral load testing has been set up with these systems already. So just to give you an example, in Africa, the Abbott, you know, this HIV viral load testing in South Africa, there's about 16 labs that are set up to do that, and they do about 5 million tests per year. And it's a very centralized setup, particularly in South Africa. So they might use the dry blood spots that Tom mentioned for a lot of these tests, or even dry sputum tests. But you might think that throughput and centralized would decrease in turnaround time. But the National Health Laboratory Service in South Africa has actually done quite a good job of making sure turnaround time is not that high. So about their goal is to have 75% of tests return within 96 hours. And they've actually exceeded their goal. 86% of their tests are turned around in 96 hours. So beyond HIV viral load testing, I mentioned they did 5 million tests per year in South Africa in 2018, 2019. But actually in TB testing, this Cepheid instrument right here, there's been about 10,000 placements of this instrument in settings where TB is of high incidence or prevalence relative to other diseases. And so 10,000 instruments have been placed across many countries in Africa, which can immediately get online and start using the COVID test that Cepheid has added to their platform recently. In South Africa alone, they've run about 15 million TB tests on this platform, and they really do the high throughput. They have one that processes 80 samples at a time. So again, leveraging that wonderful system they have, laboratory system they have in South Africa. So despite this, these platforms, this is John Nkengasong again, who leads the African CDC. They are having the same challenges that I think many states here in the US are having in terms of access to buying the cartridges or the reagents that go into these machines. So they might have the machines, but they can't really get their hands on cartridges. And I think this might be particularly true for either places that don't have the machines already, or places, smaller countries that maybe just don't have the same buying power as other countries in the world. But in short, I think there's suppliers that see this large mismatch in supply and demand and are responding. As a result of that, we see a lot of new molecular tests and immunoassays, or lateral flow tests, that are entering the market. And Find has done a great job of trying to catalog the tests that are in development or commercially available. Right now, there's about 620 that suppliers that have self-submitted their assay to the Find website. I would say about 300 of these you can select on the Find website if you're curious how many are immunoassays versus molecular assays. But about half are immunoassays and the other half are molecular. In addition, of these 620 tests, actually about 520, they're self-proclaiming, the manufacturers are self-reporting that they're about 520 are commercially available. So there's a lot of, I guess in the diagnostic world, we would say sort of noise and trying to figure out which one of these tests are good has been a real challenge. And Find has tackled sort of finding the good test from the bad tests in two ways. So the first is through an open source evaluation process. So if anyone on this call has evaluated an antibody test or a molecular test and has performance data on that test in the field, you can actually go to Find's website and submit the results of that testing, and it'll be crowdsourced onto sort of these beautiful graphs that can show you where sensitivity is maybe not so good, or where specificity is maybe not so good. Also, you can find out which ones are performing well. We see a lot of really bad tests flooding the market, particularly from markets that don't have access to better tests, sort of out of desperation. And so having good performance data like this is certainly helpful. The second way that Find is doing this, rather than having labs that are performing independent evaluations of tests and posting them online, the second way they're doing is they're doing an evaluation themselves. on both molecular and immunoassays. Manufacturers of molecular assays submitted about 200. They had 200 people submit their assays there. And then Fine down selected 21 specifically in the manual open PCR category. And then they posted those results online. In terms of the immunoassay, they're still getting started on those evaluations. They picked a handful of the 100 submitted. They picked 5 antigen-based RDTs, or the rapid tests. They picked 27 antibody-based RDTs, or rapid tests. And then, as Tom talked about, there's another way besides to do an immunoassay on a platform, and that's an ELISA. So 7 ELISA tests are evaluating. So if you're interested in the results of this test, you know, I think they're evaluating them right now, but it'll be good to monitor and watch as these evaluations come out. Finally, there's an organization called Halteris that did a really nice job of putting together 9 potential use cases for point of care COVID tests. And if anyone is developing a test, I think it's worth a read through to just see their thoughts on this. They're a tremendously well-respected group of individuals that have been doing use cases for all sorts of diagnostics for decades. With that, I just wanted to again highlight some of the great work that various organizations are doing to sort of kind of create order out of the chaos and coordinate both the supply and the demand side. I thought these resources were particularly useful. So thank you very much. I'll hand it back over to Claudia for questions.
Thanks to all the speakers. Those were fantastic presentations, and really, I think we learned a great deal about what's going on at Northwestern and sort of the larger global application. So we have a few minutes for questions. I will start with one that came in for Dave. I think he's still here. I can't see him. Oh, there he is. So Dave, a question for you. Has there been work using your instruments on correlating actual viral load with CT values?
We haven't done viral load. The closest that we have come to that is with synthetic RNA. In fact, if I can show you, I saw the question come through, and I can show you a slide of that data. I think I can. No, I can't. But we've gone down. We can see we have a nice linear curve going down to 10 copies of the synthetic RNA, and then going up 4 orders of magnitude. So it's a nice linear curve. We've got really good sensitivity with it. The other thing is Sally. This again is Sally McFall's data. She's also challenged it with the SARS-CoV #1, and she can run that up to a couple of 100,000 copies, and we get no interference. So we've got very good specificity and good sensitivity. And actually, one of the medical questions, which we started a dialogue with the Feinberg folks about, is what kind of swab to use. So Rob Murphy has introduced us to Gary Noskin. I had a good long conversation with Greg Retzinger, and we'll be talking with Dan Durman and Heather Kierman soon to see what's the best sampling technique to learn. Because as you know, there's big differences between whether you go all the way back with the nasal pharyngeal swab or just do a nasal swab, or people are talking about doing saliva now even. So we've got a lot of early work to do with what are the best sample types to get in order to have the required sensitivity. So that's what I've got on that.
Great. A question for Tom. What's the time frame? Someone's asking what the time frame is in which you might scale up your DBS technology and antibody testing to send out to people at home.
Mm-hmm. Yeah, that's a great question. I think there are two limitations potentially. One is the equipment and the people who can run it, and the other is the infrastructure for getting information from people, sending out the kits and that kind of thing. With the group of collaborators that I mentioned that I'm working with right now here at Northwestern, we have 2 labs that have immunoassay equipment, and we're comfortable saying that we'll be able to analyze at least 1,000 samples a week with the current infrastructure. We could easily double that by hiring more people, and then doubling that again would require additional equipment. But there are lots of other labs at Northwestern and at other universities that have the equipment. A plate reader, a plate washer, you can get decent ones for about $15,000. So there's not a huge infrastructure cost in terms of the lab. I mean, that's not nothing, but there is a lot of existing infrastructure that can be used to scale up pretty quickly.
Great. And then someone asked, can you give me, I'm not quite sure who this is directed at, but can you give me examples of diseases where the presence of antibodies, for you, Tom, does not confer protection against that particular germ? Some experts are using this as a caveat to antibody testing.
Yeah, well, it's going to be variable based on the disease, and we don't know enough about the current SARS-CoV, this version of this coronavirus, and the extent to which antibody tests confer immunity. So that's a very important question, and I know a lot of people are working with that. Rich Tequila here is having conversations with a number of those people. It's also important to keep in mind that that the levels of antibodies that people have change over time, right? So a test at a single point in time doesn't necessarily mean, even if that does signal some immunity at that point in time, that doesn't necessarily mean that it will confer the same degree of immunity in the future. So we have a lot of work to do on that question.
So a question for both you and Dave, and maybe Cara too. I'm curious to know how your platforms are going to perform sort of wider scale, and what kind of challenges you might have thinking about using them in low middle income countries. I mean, South Africa is more resourceful, or has more resources obviously than other African countries, and I can see the immunoassay having some challenges there, but just curious to hear your thoughts from both of you on those types of technologies and how usable they're going to be in those settings.
This is Kara. I'll start. I mean, I just think getting it embedded into the existing supply chain. The existing ways that chemicals get to machines, or ways that machines get into labs, I think that's one of the biggest challenges to establish, go down the same path that other bigger organizations have already gone down.
I think I can add that as far as Tom's technology goes, there is a whole infrastructure in place for dried blood spots. That's how they test children for HIV when they're born, and the dried blood spots go in and the answers come out. So over the last 10 years, there's been a whole infrastructure put in place for doing that, collecting the dried blood spots in the clinics and getting them tested in the labs. And so that'd be terrific and easy to integrate into their system.
Yeah, I agree. And I've worked with several researchers in different countries, China, Indonesia, Mexico, South Africa, on sort of adaptation of already local expertise with the use of blood spots for serological testing for antibodies or markers of inflammation. So I think that there's a promising infrastructure in place for ramping up in those settings.
As far as the PCR goes, that's how it was designed to be stable at ambient temperatures that you see in the tropical settings. As Kara mentioned, you still have to get the kits to the labs, but the fact that it can be run by basically anybody. There's no medical lab techs required to run it. Interestingly, we've seen pushback from the nurses because they don't think that's part of their job, and they tend to want to push the testing into the phlebotomist room and let someone in that room do it. So there's all those usual real world issues be dealt with. As far as the technology goes, we've got something that's small and lightweight and stable in those environments. So it's perfectly, it was designed for them. And we can put a HIV viral load on it, put TB on it, do the tests that need to be done the rest of the year there, as well as these pandemic diseases.
Great, thanks. There's one last, we're coming up to the hour, so actually over time, but just one last question for Tom, I think. Does the lab need a biologic cabinet to run the ELISAs?
So my lab is biosafety level 2 certified, and we're not working with live virus. And for one of the advantages of blood spots is that everything in the sample is dried, which almost for most pathogens renders them no longer viable. So we're not doing anything differently. We have biosafety cabinet and we do things in there, but it's not actually a requirement on the work that we're doing right now, is my understanding.
Well, with that, thanks again very much to all our speakers. It was a fantastic seminar, and any participants who didn't get the opportunity to ask questions can also email our speakers, and we'll wrap it up there. So thanks again, all of you.
Thank you.
Thanks.